Hey. Wonderful. Hello, everybody who's joined, and welcome to this afternoon session with me and our wonderful presenters today. Before I make a start, I'm just going to quickly welcome our speakers today. So, first of all, my name is Navjot. I'm the head of value based healthcare at Swansea Bay University Health Board and the assistant director for data and analytics at the Welsh Value and Health Centre. And I'm really pleased to be joined by Dr. Uma Nair, who's a consultant radiologist at Betsy Cadwallader University Health Board and is a key member of the team who have set up a one-stop neck clinic at Isbiti Gland Clwyd. I'm also delighted to welcome Dr. Inder Singh. Inder is a consultant physician and geriatrician with an interest in falls and bone health based in an Iron Bevan University Health Board and is the national clinical lead for falls and frailty. And of course, our lovely Sarah Pantoni. Sarah is the program manager at Welsh Value and Health Centre, working nationally across NHS Wales. So if you can all do a wave to our audience, that will be fantastic. Uh, Hello, everybody, and delighted to have you here. Before I make a start, I would just like to go through a little bit about this event and so what's happened so far in this event. So really, we've had a wonderful 3 days already. We've had introduction to value. We've had sessions on what value means to multidisciplinary groups in Wales. We've had discussions around the importance of finance in value, outcomes in value, and of course, how do we use digital in value-based healthcare. We've had a number of our policy colleagues from the Welsh Government, and this session is very close to my heart because it's all about hearing from people who are making things happen right now. So, ladies and gentlemen, these are value voices which are making an impact, giving us the chance to hear about projects and programs that have value-based healthcare running right through and at the center of them all. So in terms of this, the structure of this, I've already introduced my speakers to you. So we're going to hear from all three speakers on their work, and I'm going to encourage you, please, to use the Q&A the Q&A bar. I've put my comments on that already whilst they're speaking, but then ask the questions at the end of these presentations. So there was already a session on value voices this morning, and I would encourage you to go to our YouTube channel where all of these sessions are recorded, and I'll post a link to the YouTube session on the Q&A panel later on as well. And maybe then a little throw forward to tomorrow's sessions as well. So the final week of the session this week is at 10:30 to 11:30 tomorrow, and it's all about the future of what is next for value-based healthcare in NHS Wales. And Sally Lewis, who's the director for Welsh Value and Health Centre, is joined by senior NHS Wales colleagues to discuss what 2024 has in store. So I think enough of me talking now, and I'd hand over to our first speaker of the day, Dr. Uma Nair. Over to you.
Good afternoon, everybody. Can you all hear me okay?
Yes, we can, Uma. Thank you.
And you can see the screen as well. And Gareth, you ready?
Yes, we are, Uma.
Yes,
Okay.
ready.
So I'm a head and neck radiologist with a special interest in cancer radiology, and the usual sort of cancers that I come across are cancer of the tonsils, cancer of the pharynx, cancer of the tongue, salivary glands, and usually thyroid. And a lot of the times, patients who have these cancer don't even know that they have a cancer, but a lot of the times they have a lump in their neck and they notice it themselves. Their relatives or friends say, oh, you have a lump in the neck. And that's how these patients come to us. And sometimes we don't even know where the primary is, but they have a big lump in their neck. This is the unique feature of head and neck cancer because a lot of other cancers, for example, cancer of the colorectal region, cancer of the gynecological sites, they also have lumps, but these lumps tend to be in the pelvis and patients may not notice it. In cancer of the lung, by the time they end up having a lump in their neck, they are usually terminal and beyond any sort of cure. And the unique feature of head and neck cancers is that even if they have a big lump in their neck, they can be treated, and a lot of the times they can be cured. So that's why, as a head and neck radiologist, we have a lot to offer in this region. So when a patient notices a lump in their neck, they usually go to their GP and say, I have a lump. And this is how a lot of these patients come to our ultrasound clinic. So when we get a referral, we see these patients and we scan them. And if there is a lump, we take a biopsy if that's required. The sample will be then sent to pathology. Pathologists will analyze it, and then within a week, usually, but sometimes 10 days to 2 weeks, a result, a diagnosis will be achieved. A lot of the times it may be cancer, it may not be cancer, and occasionally the diagnosis may not be achievable because the sample is not enough, in which case we'll end up recalling these patients and rebiopsying them. Sometimes a fine needle aspiration may not be enough. We'll end up doing a bigger biopsy, which we call a core biopsy, and then it will take another 7 days for the results to come. And then eventually we reach a diagnosis with the help of pathology, and then patients know what they are having, and then the GPs come to know, and the GPs will then refer these patients to ear, nose, and throat or maxillofacial surgeons for further assessment. They will then be seen in their clinics. They'll have their primary head and neck sites analyzed. They'll further have biopsies, and then so on and so forth. So if you look at these patients' journeys, you can see that multiple small steps happening, each adding to a delay. And when we finally get a diagnosis, and then they know that they have cancer, and they have to be presented in a multidisciplinary team meeting so that the oncologist, the pathologist, the radiologist, the ENT surgeons, they can all sit down and look at what the patient is going to have. And in order to, so if you look at it, there is a lot of delay happening in this patient journey, which can be avoided. So the the significance of a one-stop clinic happens in this context. Next slide, please, Garrett. Okay, thank you. So if you look at the delay these patients are having, there is a delay in getting the ultrasound clinic appointment in the first place. There is a delay in biopsy. There is a delay in getting the biopsy result. There is a delay in getting the patients to the clinic. And then there is a delay in MDT. So that's the reason why we decided to set up a one-stop clinic where we can do all these steps in a single clinic. So we needed to develop a multidisciplinary task group for this, which included radiologist, pathologist, ENT surgeons, cancer specialist nurses, healthcare support workers, cancer services, primary care, and patient representatives. And we set up the clinic. Before that, we needed to agree on a referral criteria after consultation with everybody. And the aim was to replace these multiple visits with a single appointment where a lot of these steps can be done in a single day. So the idea is to scan the patient in radiology first, have the FNA taken at the same day. If needed, they all received a core biopsy as well. Then after the biopsy, a runner will take the samples to pathology, and a healthcare assistant will support the patient and take the patient to the ENT clinic straight after the radiology appointment. So by the time in the ENT clinic, the patient is seen and examined, the result from pathology will be there. And the average time is about 45 to 60 minutes. So the patients will know the diagnosis on the same day. It might be a cancer diagnosis. It may not be a cancer diagnosis. Sometimes the patients can be told that, look, what you came with the lump that you felt is nothing serious and they could be discharged. And if it's a benign diagnosis, they could be reassured as well, and they could have a treatment plan done in a slightly different pathway. And sometimes patients get a cancer diagnosis and they can be comforted. And then further treatment decisions can be planned. And the first step will be gearing them towards preparing for the MDT. Next step, next slide, please, Gareth. Thank you. So I think we went through a lot of the things in that slide. So next step, next slide, please. Yeah, and the next one. So this is the clinic template. So we could do 6 patients. We scanned 6 patients, did 6 FNAs, and if needed, we did core biopsy whenever that was indicated. Um, we had the ability to include rebiopsy as well. For example, if any of these FNAs or cores that I did was inconclusive, I could call them back and do them on the same day so that we could find out what's happening on the same day. I could include 2 slots for marking, neck lump marking for same day surgery. This is not for cancer, but for parathyroid adenoma surgery. And I don't think I have time to talk about it. If I can, I will do that later on. So we did the pilot clinic in August 2021, and we had excellent feedback from our patients. So we had we have the ability to do a diagnosis on the same day, and a lot of patients could be discharged and reassured. So that was a very positive thing from a lot of patients' point of view. They came worried and they left the clinic, happy, knowing that they don't have cancer, um, and so on. Next slide, please, Gareth. Thank you. So now the clinic is expanded to an afternoon session as well. Um, so um, um, so that's where we are now. And next slide, please. So our service was recognized recently, and we achieved an award for our excellent service. So we are quite proud of that and proud of what we managed to achieve. So thank you everyone who helped in getting this all sorted for us. And it just shows with what multiple teams can do when they come together and bypass a lot of unnecessary steps and do what's best for the patients. And so I'm very thankful for this opportunity to show off what we have done and what we are very proud of. So, yeah, thank you.
Thank you, Oma. What an excellent example of value-driven care, and I'm sure there'll be loads of questions from our listeners. Really amazing. Can I ask Inder to now come in and actually another amazing value voice in the system. Inder, over to you.
And I must thank with the Welsh Value and Navjot or your team for having me here today. And actually, you have been a key people who actually got me a little bit more transformed into the value. And I think I was working inside us before I met you guys. So yeah, no, and Gareth, thank you for getting all this up running for me. I'm going to talk slightly, very much on a similar lines what Uma has done in radiology. Uma, I have got a very strong relations with radiology colleagues, and most of friends are radiologists, and you guys can do wonders. We know that already. So, and also
Thank
the
you.
stepwise approach you will see now in some of my slides, and and I think there's no brainer. We need to avoid the steps in our processes in our services. It just wastes your time and actually lead to patient harm. And so value is lost, but patient harm is the major part, which I'm going to just allude in some of my slides here today. So I'm going to use the example of a fracture layers and services. If you haven't heard this term before or haven't heard about this service, it's absolutely fine because I know most of us do not respect our bones. So it's okay because we do not feel that bones are living organs. So next slide, please. So what we see now is in this slide that every 2 minutes, somebody in the UK is having a fracture. Now this is 2013, but when we reach 2020, that 2 minutes has gone to 1 minute. And as we speak today, there are 3.5 million individuals, both men and women, are living with osteoporosis in the UK. So first myth is out. It only affects old, frail, older women. That's not correct. It affects everyone. And bones are living in all of us. Next slide, please. So, so what? If you had a fracture, they go to radiology, they go to A&E, they go to trauma, da 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 da, and they cost a bed and they cost a care home. It costs very much. Is it just that? No, it's much, much more than that. So if you see the next slide, please, you'll see it leads to these many hip fractures in Wales. And even if I put the context of 345 beds being consumed annually in Wales, that's a huge number of beds being used. And we cannot avoid every hip fracture, we know that, but we can do something different about this. If you look at this, about 5 to 6% people die at 30 days, and 1/4 does not return back to their homes. They require like a care home, which is very expensive, and we do not have any care homes in Wales. And the number game is very, very short that if we can construct more, no. So we have to manage these people in the community, and there are valid reasons for that. So next slide, please. So if you look at this slide, if they cannot walk and they require that care home, that's not a quality of life. But this is not only a hip fracture, it's also a vertebral fracture. So 2/3 of them will be living with that back pain. They require 14 visits per year for the pain management. And all these fractures are seen by my kind colleagues, radiologists, and sometimes not being picked up. And if they're picked up, not being attended to anybody in the clinical teams. But all those falls and fractures doesn't let us stand upright so that we're not confident. Sometimes we're just housebound, loneliness, depression. Sometimes we cannot even feel like we can go to the toilet because we're still under that fear of having another fall and a fracture. So hugely impacting communities with those little fractures of the spine or humerus or wrist. And they live with that fear forever. But these are avoidable. So next slide, please. So what happens with this? In this graph, you'll see that there is a chance after first fracture within the next 24 months to have a second fracture. So when we have a second fracture, the whole pulava, what we just discussed in the previous slides, get only worse. So I'll take you back to the original hip fracture list. So next slide, please. So if you look at the hip fracture which happened in 2020, 2 years down the line, there are extra 12% hip fracture added, which mean approximately 1,000 hip fractures more. And that's a very, very big number added to the original number. So if they had a one hip, the second hip is at risk. So 1 in 4 are going to have a new hip fracture within 2 years' time, just because they are frail and they have osteoporosis and they're going to fall again. So we haven't done what we could do. So next slide, please. So this is the NHFD data. So if you look at the first figurehead, I was going to hide the second one, but it's the 72,000 fractures observed in year 2022. But if we compare with the previous years, there are 66,000. So we mean extra 10% fractures have happened just as compared to pre-pandemic era. That's a big number. What does it mean to Wales? Wales have got 13% increase. So what does that mean to us today? Is a 549 extra hip fractures in Wales. And all we need to do is multiply that 5, and that is equivalent to extra fractures in Wales we have seen in addition to the original. So that means in total in Wales, we have 30,000 fractures coming our way every year. And more alarmingly, 1 in 3 will have a refracture of those. So if we start with 30,000 today, next year 10,000 added to that. Sounds bad. So we are going to drive uphill, and the boat has got a lot of holes now because there are no services. Even if we manage to just go uphill, we will still not be surviving. So next slide, please. So that's where the FLS comes in. Next slide, please. So that's where FLS, which is the fracture agent services, which mean the moment radiologists have seen a fracture, we can identify at that point and we can see straight away. So And that's the joy of having this type of services. It's very much similar to one-stop services, what Uma was mentioning, that once we see these services, it works in our favor. I'll just turn my phone off. I should have done before. My apologies for that. So if you go to next slide, please, for me. So that's the model. We should be able to identify 80% of these patients. We should recommend 50% treatment to such individuals because not everybody can have it or tolerate, or they could be contraindicated. But once we have identified 80%, treated 50%, the most important part is that we follow up those 80% for 1 year before handing over to the GP, because these medication and a false care plan and a pathways do not work if these patients do not get attention for a year. We are dealing with the most vulnerable group in our society or in the community, and they do need a lot of attention. So that's why the KPIs has been 80% for those individuals once we identify and started treatment. Next slide, please. So that's the patient journeys. So Uma, my journey is not too different from yours. So patient with a hip fracture come to the A&E, get a clinical referral, week 1, week 2, they go back there, followed by that, they reach GP. So if you click once more, they go to GP, GP will have a look on a discharge summary from a trauma orthopedic, and then they go to the next step. They get referred back to us again, and we triage and see. And if Dr. Singh is not doing anything else, I'll see that patient. But I know I'm busy. It's not going to happening at 16 weeks as well. This is going to take 20 weeks plus before we even start talking about the bones and hips. So if you click on next time again for me, once more, that's what we want. That we once more, sorry, slides are a bit different. So no, previous one, please. Previous, that's it. So if we have a really good integration with radiology, rheumatology, COTI team, and trauma, spine surgery, can it just click once for me? Thank you. Just once more. That's it. So we could see these people within days, not in weeks, because I get report from a radiology every Monday morning, all the fractures which had happened a previous year. And job done. I don't need to know anything else. I can triage them, I can call them, I can review them sitting in this hospital. I can manage all the Gwen patient because surgeon is doing their surgical job. I'll do my job sitting far away and I can prescribe them medication, talk to them. And then if I need to do false risk assessment, I can do remotely. Even if I see them face to face, so what? If I need to strengthen the muscles, I need to manage their cataract or dementia, we got the services, we got community, how we bring everybody together to manage that vulnerable adult who has got fracture already. Next slide, please. So these are the few initiatives, and I'm just going to phrase them in one if you just put it out there. So what we have done is we have put a framework, and that framework only talk about quality, nothing else. So it's a quality planning in this work. There's a quality control, which we manage and make sure we are getting full reassurance on that. And we continue to work on quality improvement. And we got 3 key priorities for this, that we need to improve our identification, management, and care, so that we're linking more and more with the A&E front door and radiologist, wider integration and partnership. And that's why I'm here today working with Welsh Value team. And then raising that awareness and education among us, among communities, among patients, everyone, so that bones are taken as everyone's business, because we all have that. So next slide, please. So we shared this with the Welsh government, and Minister was very, very impressed. And whenever I tell anybody we have achieved this, I've achieved a lot, but this is just a beginning. So Health Minister has already issued a written statement, and Minister has clearly mandated that we need to have FLS services across every part of Wales, and it should be 100% coverage by September 2024. It's the coverage, not achieving all the KPIs. So next slide, please. So this is the data which I want to share. If you click the next slide, there will be few clicks. So if you look at this, this is what we have at the moment. So this is the KPIs. So we have 11 KPIs in Wales, and not every health board participate in. And I must say health boards might be delivering these services. But on this data sheet, we only see 3 health boards, but quite a bit red. So if you click once more, Gareth, for me, please. So you will see now Wales have got 3.8% identification in the year 2022. right? If you just remember this, in the year 2021, it was 21.8%. So we improved approximately by one third or whatever figure is. Clearly improvement in the year 2022. So if you click once more, and we clicked on everything except the annual reviews. So annual adherence is the most important part for these individuals. No point starting medication if you cannot assess them, they're taking it regularly. So if you go to next slide, please. The next slide, very similar. Click once more. Same 38.3, click once more. Now this is the 23 data. Now 23 data is telling us we are doing better. Now this data is up to the end of September, and we are hoping we will improve our identification to 40% plus this year. So that's where we are heading. But the key aspect is now, if you look at the KPI number 8 and 9 and 10, you can see there is a continuously improvement heading as well into those areas as well in the year 2023 as compared to previous year. And that's the improvement we need to see. When you identify, you see those patients again, review them, and continue to educate and make them aware on the treatment options. So next slide, please. And that's the best slide of the day. Showstopper. So that's what I have done with the Welsh Value team. I know it says in the saying it's not my name, it's the name being given by the Welsh Value, but I don't know why. I've just pasted the slide exactly as it is. But if I add primary prevention to that and end of life, all the KPIs I've mentioned so far, it covers everything. So which simply mean rather than doing a secondary prevention, why not we doing a primary prevention? Whilst we were discussing this, we said primary prevention at what age? Because moms usually tell toddlers to go to school, play outside, weight bearing exercise, drink milk, sunlight, etc., etc. I've just added antenatal care to that. So I said, why not to start at the time of conception? And we continue respecting our bones till we die. So if you click last time once more, the next slide, and we have put different types of metrics now. So rather than having a national KPIs, and I love these KPIs. So imagine if somebody had a fracture in Wales and we can measure away days from home, or we can measure the change of residence at outset. We know exactly which direction we are going in Wales, if we are making any value for money or not. And could we monitor the pain attendance to the clinic? And if we know that pain attendance is 13 today, and 3 years down the line, it has come down 10, we can congratulate ourselves. The reason behind is we are the one who will be using these services. So if we do not develop it now, we will be living with that pain and a bit of a loneliness and depression in our own homes and won't be able to use the toilet or have the basic function which we deserve. And that's where I end with a lot of thanks to everyone.
Thank you so much, Inder. I think the next screensaver we'll have in the NHS will be called "Respect Your Bones." It's inspirational. The story, and I have loads of questions, and I'm sure you'll get them afterwards. So, uh, Sarah, over to yourself.
Thank you. I'm going to talk about something a little bit different today. I'm going to talk about a national or population level survey that we've been running in Wales. Is part of the OECD, is an OECD benchmarking exercise, and I hope you're all familiar with the OECD. Next slide, please. So Paris is the international name for it. We've always run it as the population survey for Wales. It's the first international health outcome-based study for the OECD. Is effectively consists of two surveys. One targeted at GP practices, and of which we needed to identify and recruit 75. And then there's a patient survey as well. And that is targeted to adults over 45 that have chronic conditions and are managed by the GP practices and have seen their GPs in the last 6 months. There are 20 countries taking part, including Wales, and we're the only UK nation taking part. England did take part in the original feasibility study that ran last year, but since then they pulled out. We went live with the recruitment in April. We closed recruitment in October, so we now closed. We're just waiting for our data to be returned to us. And the OECD flagship report is expected about December 2024. It's slipped a couple of times already, but I don't think it's going to slip any further than that. Next slide, please, Gareth. So if we start with the GP surveys, we extracted the GP providers about a year ago, and at the time we excluded any GP that practice that was too small, or for example, we knew they wouldn't have the right type of patients for us. For example, GP practices based within universities. We advised a total of about 385 practices. From those, we identified 199 proportionately. So we select them by geographical location, so by health boards, and then depending on the size. So we were small practices, medium and large. We were very, very lucky to have the support of the Royal College of GPs and GPC Wales to help us getting the information out to the GPs and raising it to their attentions. And all communications was very much targeted to the practice managers. The recruitment, obviously, as you would expect, it was bilingual. Now, the recruitment for the providers from April to May, and we were very lucky with the response. It was really good. We got our 76 practices. So in fact, we smashed the OECD target, and we were able to close a week early. We were one of the first countries to be able to do that. So we did very well. Next slide, please. Patient survey, that opened in July and closed in October. We originally went out to so if you remember from the first slide, the OECD target was 45 adults over 45 with a chronic conditions that's in the GP in the last 6 months, and they needed to be linked to the GP that have completed a survey as well. However, in Wales, we were very keen to use this as a population needs assessment. So we wanted to look wider than the OECD requirement. So we went out to recruit 400. So we went out to 400 patients from each of the 199 practices that we had originally invited to take part. We provided options to patients to complete it by paper, over the telephone with a free helpline, or over the computer online. Everything was bilingual, but we also added 4 minority languages, and that is Arabic, Ukrainian, Polish, and Bengali. However, the minority languages could only be completed using the language line model. Now, the chronic condition and last appointment were self-reported, so we contacted patients based on their age and what practices they were based on, not whether they had or not a chronic condition. So again, we looked wider of what the OECD requirements were. Next slide, please. The survey was long, very long. It took about 22 to 25 minutes for patient to complete it. So we asked a lot of questions. It's a very thorough set of questions. It looks at the quality of life, the well-being, the lifestyles, the sort of activation and person-centered kind of measures. So things such as shared decision-making, goal setting, people's confidence in health, trust in health. We asked about the last appointment, who was it with, what was the outcome, what was their experience, how long did they wait, were they happy with it. Chronic condition management for those that have chronic conditions. We also looked at wider care utilizations, and we asked questions about people's support networks. So again, it looks wider than just health. He asked them, for example, whether they have, if they need help from the neighbours, would they be able to access it and how easily. So it's a very comprehensive questionnaire or set of questions. Next slide, please. So the first 400 patients that we wrote to, they each received a letter through the post, which included a postcard. The postcard was to request a paper survey. They could post it back to us, and they could identify whether they wanted an English, a Welsh, or bilingual paper questionnaire. And then the language card, which obviously had the 4 minority languages, and directing them to the free helpline. We then sent reminders about 2 to 3 weeks later, and that was another letter. And to save cost, we send the letters at the same time as we send all the paper requests as well. So again, just to have that bulk cost savings from posting it just once. We also sent SMS reminders that were timed to try and land around the time of those letters being received as well. So the first cohort was really good. We had a response rate of over 36% overall. For the OECD practices, we had a slightly higher response rate of 37%, and that was brilliant. Now, if you remember, the OECD requirements was 75 patients from each of the 75 practices taking part. throughout, we kept tracking all our responses to see where we were landing on that against that target. And because chronic condition and last appointment were self-reported, even though we needed 75 patients from each of the OCD practices, we actually needed 120, we thought, to be able to account for that self-reporting. And by the time August came, we weren't really sure whether we were going to meet that for all our 75 GP practices from the OECD. So next slide, please, Gareth. So we contacted a further 400 patients from those practices, and that was a very small mailing in the sense that they only had the postcard to send back for a paper questionnaire. There were no reminders, no text. Same model of collection, obviously, nothing changed. But we kept it very, very, very simple. We just wanted to bump up the numbers for those practices. Overall, that reduced our response rate. It's still brilliant, I think, for what it is. Obviously, it did bring it down a little bit. So as of today, we still haven't had our data back, but we do know that we have 120 survey responses from all of the 75 GP practices. So we are confident that we met the OECD targets. And when you look overall across Wales, we only have 13 practices that are just short of the 120. So it's a very representative cohort numbers-wise, at least, and geographically spread as well. Next slide, please. So this is the data set that we're expecting back. So we have 75 GP practices, even though 75 were the requirements. We also have 29 partial completions as well. And from the patient side, overall, when you put the partial completions and the full completions, we're just over 30,000. So it's a massive data set that's going to come back to us with a lot of data and information that we've never had before. Next slide, please. So as I said, the flagship report will come out next year. 2024, so there's quite a timeline until we get that data and that benchmarking information. But in the meantime, we can do our own analysis. We're expecting the data back within the next week or two, and then obviously we'll have to do some data cleansing. All that data will be patient identifiable, so we'll be able to do data linkages with every other information that we have, nationally held, obviously. So we're gonna have to do a prioritization exercise. What do we want from this information? What are we going to prioritize first? And I think that's going to take us to the next financial year when we can start actually, hopefully, start doing some analytical outputs and feedback to the practices that took part as well. I think that's my last slide. Thank you.
Excellent, Sarah. That was amazing. What an amazing outcome, and what an amazing journey. Thank you so much for that. So thank you to all our presenters. And I've got a few questions already in the chat. And thank you, Lucy and Gower. You stole some of my questions, by the way. And just as a matter of fact, I'd just like to say that Lucy and Gower and myself are probably the fewest engineers in the NHS you see. So I'm very glad to see questions from fellow engineers here, really, to the medics. Okay, so the first question in there, Uma and Sarah, and if I can follow that order, if that's all right. Could the presenters tell us about some of the challenges that had to overcome during project planning and implementation? So we start with Uma first, then with Inder, then with Sarah. Uma.
Okay, so I have to say, the clinical support that I had was excellent. I had some challenge in getting the full list sometimes on a Wednesday. So on a Monday, my clinic happens on a Wednesday, and I expect the list to be full by Monday. At least that's the date when I decide, oh, there is a slot waiting, and then that's not filled yet. So I have to start running around finding a patient for that. And occasionally, 2 or 3 slots I had to fill. And when we tried to get to patients at short notice, and explain that you're going to have a biopsy and sometimes a bigger biopsy and all that, patients get terrified. And, there was the risk of losing the slot sometime, which we never let happen, but it was quite narrow. So that was one of the challenges. And the second one was we sent, letters to patients asking them to come to radiology first, because that's where patients are seen first. But there was a mix up in the letter saying, there were two sorts of letters, one asking patients to go to ENT, and patients will end up going to ENT, and we'll be just waiting for them, wasting a bit of time. So we had to go around and find patients. So apart from those two issues, which are getting sorted now, everybody, they wanted to make it really happen. So yeah. So, lot of support from the management really. And yeah.
And thanks, Suma. And in my head, each one of your stories reminds me of the multidisciplinary collaborations that we
Mm,
rely on in our healthcare
mm,
systems. So I think that's really excellent. And thank you for telling us that. Inder, over to you.
No, thank you, Navjot. And I must echo what Uma has said. But I'm not going to say that is only the our our intentions, motivation. We do need resources for that. So I'm going to put resources on the top of one of the challenges. And this is still ongoing. And I might be able to answer the second part of the question as well for, I think from Lindra. It's about the how to calculate the economic benefits. We have got economic benefits done by the ROS team. So if we invest £2 million in Wales, the annual saving over a period of 5 years, with that annual investment of 2 million, we're getting a 5 million return. So positive balance is 3 million. So if that can be done using stats from the economic calculators by ROS, based on the money what we spend is already there. So I don't want to reinvent that wheel if it helps. But
Mm.
let's go to the next battle. So my health board has given me 148K based on all the persuasion, but it started with the pilot work. So one thing which I strongly recommend anyone, if you want to have to any services, anything, always do a small pilot. And you must have your outcome evaluation with you. And that evaluation should have different faces to it. Should have the benefit to the organization, because they'd like to know that. So it could be a length of stay or bed stay or whatever. Should actually see the benefit to your staff as well. So if they're getting less stress and less benefit with that, and they're becoming little more productive at work and efficient, surely you need to have a patient evaluation and feedback to that, because they are your stakeholders. Always do a smallest possible pilot. Go with the pilot to your health board. And that's exactly what I started this journey 3 years ago. And I started with a one nurse who only used to give me 2 sessions in a week. But then we gradually gone to 2 days, 3 days. Then I got for full one day. Now I got for 2 days for two whole time equivalent nurses. But then they need an administrator job. You again need to evaluate if a band 7 is doing a band 3 or band 4 job. I respect that a band 3 has got the job, but they shouldn't be doing a band, this band 7 shouldn't be doing a band 3 job. So again, monitor the services regularly and bring it back to the execs or service managers that this is where the not best use of the money is. But let's say we got money. So what? I think the key challenge after having money is recruitment. And even if you recruit, so what? If they're not fully trained and not fully being supported, it won't work very well. So in fact, I had a feedback and one of the CNS actually was going to leave. And her answer was, and I said, please tell them what's the issue. And it's a real story. And it only happened 3 months ago. She said, I'm not supported. I said, what happened? Oh, you come, you just do the clinical part. You haven't asked about me, how I'm coping, what can I do differently, well-being. Oh, I am sorry. And she actually took her resignation back. And now she's thriving like anything. But we do meet for coffees, teas. So their team development is often missed. And then when you have got good practice, I haven't I haven't done anything amazing what Uma you have done, but I do take the practice to different audience and a different hospital sites or a different network, so they can just take few things up. And the final part of this is if you do come across challenges, how to communicate those challenges with some solution to others. So that might help. Okay.
Thanks, Inder. That was amazing. And again, the three things I've noted down from your answer are, I think, perseverance. You mentioned resource, perseverance, and actually, our staff well-being, and how small things matter during that journey. Perhaps along with all the really valuable things you've talked about, I think that kind of really spoke to me. So really appreciate that. Thank you. Sarah, over to you.
I guess for the Paris project, the population survey, we never done anything like this in Wales of this size, so we didn't really have a model. So the main challenge, it took us about 10 years to work out just the AG, just to be able to get data that we could use and link to other data sets. It took us 10 months. We're very pleased with what we got. I think it's going to be giving us really rich opportunity to be able to maximize this data. And again, even throughout the collection and the model development, we had to keep so flexible because we were learning on the job, and we did change approaches as we went because we had to. And I guess it goes back to knowing your job and just keeping a really close eye on everything. Every day we would check the numbers, every day we would track those numbers, and we really kept on top of it, and that helped having to be flexible.
Yep, absolutely, Sarah. And the world of project management and the world of numbers can sometimes be quite a tricky one to manage in perhaps systems which sometimes don't understand the importance of it. So it's an uphill battle, and well done for that. Really, really good job. Um, Okay, I can't see any more questions in the Q&A chat. So please, again, just nudging everybody for some more questions. But if that's okay, can I ask a question, Inder, if I may start with you, if that's all right? Um, you in your presentation, and I've always noted this, that you are very, very strong on numbers. Okay, you're very strong on data. You're very strong on where the data is coming from, and that's your strength. Okay, the question is a bit tricky. How do we replicate as a system an amazingly data literate clinician such as yourself? Any tips, please?
Okay. I think it's an amazing thing what we do for our trainees. So I have a separate hat completely, which is under a training program director for HAW. And within that curriculum, we have introduced quality improvement work, which is data management from the day one. And year one, year two, they should be actually participating in the quality improvement work. When they reach year three, they do not do any more participation, but they take a leadership role of training new cohort of members. So rather than fixating our ideas to the front consultants or the people who had not much interest in data, we gone to the medical school, foundation, TPD, stage one training. So I think if we do have support from the Welsh Value team for that cohort of people, so that means we embedding the data into their heads from a very beginning part. I don't know what's happening with the Cardiff University colleagues at the moment, and I do not know what's happening with other disciplines. Is that what we're doing with the nursing teams, social support, AHP or not? But if we have to embed the data, we have to start from there. So that's one part. The second part is that the people who are currently working, I think there's a firefighting. They're actually, they're just rowing against the upstream and what I described uphill, and the boat has got multiple holes. Do whatever you want to do, you're not going to be successful. So what they have got is work and work and work. And what Uma also highlighted in a discussion is about the pathways. So I think the steps what we have in our process has been introduced, that once we get a referral, then only I'll see the patient. Why not an email? Why not a phone call? Right? But we have to break those so that they free up the time. So again, that work has to be going into that part. How we put those processes in place to make our working, day-to-day working more efficient. But I'm not a good typist. I know that. But I got lovely Jane, and I go back in my place. I'm not typist. If you want me type, I'll type for you. But if somebody else can type for me, I'll do more. I'll talk. I don't need any preparation work. I'll deliver everything. But that's my skill. But at the same time, I know my weakness. But I think knowing those weaknesses and introducing that support for the teams. The third thing, silo working. Many consultants, doctors, nurses, they work in their own team, in their own world, and they hesitate a lot to talk to each other. They have wonderful ideas, but I think that's where the responsibility of my ward managers comes in, consultant colleagues come in, or senior medical therapist. Let's meet, tell me what's happening. But having that coffee break once a month, it's instrumental. Now, I think there are a lot of people on this call. I work in a very, very small hospital. It's the smallest in Wales. And there was a time they want to close this. And this is my story. And I still decided to stay here when my mentor and my supervisor said not to go into that. It's a dark end. I said it's performing at a zero level. It's okay. If I go there, I'm not going to lose much. So that's the how data is embedded in my head. It's zero. It will only go positive, can't go negative. But working a stream up, but when we got everybody together, the whole foundation of data understanding everything is actually based in this. Although it's a small hospital, I needed only 5 or 6 people to come and work and share those ideas. So that's strengthening the links with the nurses, therapists, porters is amazing. So imagining a patient needing an X-ray in the ward, or that blood bag has to go to the path lab, you need a good porter, but how you engage with that is the key. It's not the speed of taking a blood test or requesting investigation that will work. So I think finding out the processes, and the nurses, therapists, everybody know that. We need to make them talk. I hope that helps.
That's a wonderful answer. And, we're going to come after you for telling us more about HEIW. My next question is for Uma. Uma, you beautifully mentioned, the steps of setting up the service. My question is about your resilience. And how did you maintain your resilience through perhaps some of those challenges? And how did you get this over? I know we've talked about challenges, right? But what was your personal story of your resilience through it?
Okay. When we started looking at our patient journeys, we realized that our patients wait for quite a long time between the date when we get the referral to their first diagnosis, which will affect the date from the referral to their first treatment. So the data was not very, very good to start off with. So we had to do something to make it happen, and with the help of this clinic, we managed to reduce the time from when we get the first referral to the diagnosis to about 14 days, which is really good. Yeah, and we are still looking at the data, but it wouldn't have happened without, a good MDT working. So it's not one man show at all. It's efforts from radiology, efforts from pathology, ENT, the people who are involved in breaking the news to the patients, because it's a significant event in their life and several years of from now on. So it's all happening in that one day, and it's a lot for those patients to take in. So cancer services and their support come in at that point. So we were very lucky because we had to do something about our data, and we were well equipped with. By the time we started off with a little pilot, and by the time the pilot was successful and all the evidence was presented to the health board, we had support already. But it took a long time to the pilot. It took a long time. There were talk about funding, money, job planning, all that. But once the pilot happened and we could show that how good it would be, then all the machinery started working together. And yeah, so, and I don't know if I may, if I can say about the 2 slots that I talked about, just before the neck lung clinic slots. Is it okay if I just tell a few words about it?
Do you know what? Absolutely. I'm just looking at Gareth. Gareth, would this shut automatically if we carried on for more than a couple more minutes? I'm just worried about that. Sorry.
No, you're fine, Nav. It won't.
Wonderful. No, thanks, Uma. Go off. I was just worried that Teams might just shut us down. No, we would love to hear more. Thank you.
Okay. So, as I said, we have 6 slots for biopsy and additional slots afterwards for rebiopsy and recore if that's needed. But at the beginning of our clinic, we have 2 slots reserved for parathyroid adenoma same day marking. And I'll tell you why it's important. So patients with parathyroid adenomas usually present with very vague symptoms. They present with panic attacks, anxiety, pain everywhere, very, very vague symptoms, really, symptoms of depression. And then a lot of times these patients get diagnosed with psychiatric problems, psychiatric illness wrongly. They go on taking medications, and then without any relief, they just reach nowhere. And at some point in their journey, their parathyroid hormone gets assessed, and that's how the question of parathyroid adenoma comes in. Okay. And once they have the diagnosis, they get started on treatment, and a lot of people get benefit from it, but a lot of people don't. And then the only option is to remove this tiny parathyroid adenoma. And usually they are very little. They can be anywhere from above the neck to the mediastinum. Usually 5 millimeters, 6 millimeters in size to 1 centimeter, 2 centimeters, but the amount of trouble these can cause is a lot. So the option for those group of patients is only surgery. So when our surgeons look at these patients, they have to start searching for a 5 millimeter lump from there to there, and it's really difficult to see. And the surgery takes a lot of times quite a long time, which will add to the morbidity. So, I work very closely with my ENT surgeons, and we came up with a plan. I can actually see them very well with an ultrasound. So we said, why don't I just scan the patient, find the adenoma, and make a mark in the neck? The surgeon will come on a Wednesday, that's when the lung clinic happens, and we look at these 2 cases for that day, mark the neck, and then the surgeon will take the patients. And with a little incision, usually it works. So instead of spending days in the hospital, these patients go home usually on the same day. So that results in a significant reduction in hospital stay, bed saving, reduction in morbidity. So I thought, sorry. So I thought I can incorporate that as well into the service, bypassing numerous steps. So those are the 2 slots that I've given just before the neck lung clinic for suspected cancer. So yeah, and that's really going very well as well. Really successful service, and the surgeons can't praise us enough.
Yeah. And that's priceless. All right, Uma, that's amazing. And you know what I'm thinking is, what an amazing session. And, you guys are truly the value voices in the system. So a round of applause for all of you from me and the rest of the audience, which we cannot see. But again, each and everything that you all have mentioned, Sarah, the amazing grit one requires to be the only nation in the UK to have done it. Congratulations, Inder. What did I say? The respect your bones is going to be the next screensaver. And Uma, amazing resilience, and what an achievement to set those things for patients. So thank you so much to all of you for coming here and presenting to us. And we look forward to following your value journeys very, very closely at the Welsh Value and Health Centre and as value peers in the system. Thank you so much.
Thank you. Thank you for this opportunity once again.
Thank you
Thanks
for
a lot.
having us. Thanks, Najat. Thank you. Thank you,
Thanks.
Arith.
Bye-bye.
Nice to meet you all. Bye.
Nice to meet you.